behalf of SK, Nox Health, and Nox Medical, we welcome you to our symposium today. Type 2 testing is something fascinating. The idea that we could actually do home testing, a full PSG in the home, is extraordinary. There's so many reasons to have this conversation. It ranges from the challenge we have. Full disclosure, I'm also president of the AST. So I fully understand one of the great challenges many of you have with staffing. So there's some questions that type 2 testing answers for us. One of them is if we're struggling with testing. The other one is providing an opportunity for real life testing in the home. For such a long time, the technology really just wasn't there. But we're there now. And we're happy today to have two leading physicians with us, Dr. Chris Cielo and Dr. Klar Yaggi. First off, we're going to have Dr. Cielo come up. He is a pediatric pulmonologist and sleep medicine physician and the director of the Sleep Center at Children's Hospital of Philadelphia. He is assistant professor of pediatrics at the University of Pennsylvania. Dr. Cielo's clinical work and research program focuses on the evaluation and management of obstructive sleep apnea in children. And he has a particular interest in high-risk populations, including children with Down syndrome and craniofacial differences. He is currently the PI of 2 clinical trials comparing home sleep apnea testing to in-lab polysomnography in children, funded by NIH and the American Academy of Sleep Medicine. He has been involved with committees and holds leadership positions in multiple national organizations, including the American Thoracic Society, American Academy of Sleep Medicine, and Children's Hospital's Neonatal Consortium at CHOP. He is a member of the IRB, directs the Sleep Research Corps, and is co-lead of the Sleep Circadian Research Affinity Group. In his free time, he and his wife enjoy cheering on their 3 school-age kids. Welcome, Dr. Cielo.
Well, thanks for the introduction and for the invitation. Just in terms of disclosures, as was mentioned, I do have funding for some of the research I'm going to be presenting, current and past, from NIH and from the AASM Foundation, and I'm not currently receiving any funding or in-kind support from Nox Medical. So these opinions are my own and based on some of the research that we're doing. So for those who are not in the pediatric field, sleep apnea is really common in kids, depending on the parameters you use to define OSA and the populations you're studying. Up to about 5% of kids have obstructive sleep apnea. And we see lots of kids who are otherwise healthy with enlarged adenoids and tonsils, like in the image you see there, but also a lot of medically complex children. I do have a specific interest in kids with craniofacial differences, like this boy with hemifacial microsomia. We see lots of kids with trisomy 21, children who have hypotonia, and other conditions which have been discussed at this meeting. And sleep apnea has real life implications in children. There's a growing body of evidence showing decreased quality of life, neurobehavioral deficits, and changes to cardiovascular and metabolic systems. These are just some images from the childhood adenotonsillectomy trial, which showed improvements in things like quality of life, sleepiness, and sleep apnea symptoms following treatment from sleep apnea. And I think unlike adults, it's important to consider that the first-line therapy for children with obstructive sleep apnea is surgery. And so the testing to evaluate for sleep apnea is really important because you're making a decision about whether that child's going to go to the operating room, which is a surgery that's low risk but does have real-world consequences and side effects. And then we have many other therapies, including CPAP, and there's some novel therapies that are being developed which are beyond the scope of this talk. Polysomnography is the gold standard evaluation for obstructive sleep apnea, but in kids in the United States, it's really the only test that's clinically available. And that's a challenge because it's a really limited resource. The demands for sleep apnea testing really exceed the supply of sleep lab beds. This is just a figure from one of the monthly reports that I get from our own labs, and we have 3 sleep labs there, and you can see that the wait time continues to increase. And we've expanded our lab from 6 beds when I started as a fellow. We're at 16, and we're going to go to 22 beds, but we get about 50 orders a day for sleep studies. We don't have an option to do anything other than in-lab polysomnography. And even at places like in Philadelphia, where I am, There are many other places that don't even have pediatric sleep labs available. So it makes it a real challenge. And so there's two consequences here. One is that there are lots of kids who just never get a sleep study, so we don't determine whether they have sleep apnea. And many, many, many other kids, about 90%, will actually undergo the main treatment, adenotonsillectomy, without ever having the diagnostic test. So that's really important because some of those kids may not have sleep apnea, and some of those kids, unfortunately, will have consequences from the adenotonsillectomy. Even if you do have access to in-lab polysomnography, there are additional challenges. So it's an expensive test, as people know. So it's not so easy to just increase the size of your lab and keep building more labs, even if you have the staff to do it. It can be expensive for families with copays, and also just even if it is an affordable test, it's pretty inconvenient. It's not just the patient who has to come in for the sleep study, but the parent as well. And many of those parents have other children at home. Some of those kids are medically complex. And there can be real health disparities that are introduced by having to do this test, which requires them to be in the hospital overnight. It's also stressful for kids, particularly kids with medically complex conditions. Even in a dedicated pediatric lab like where I practice, some of these kids really struggle and have a hard time with the test. And then kids with developmental disabilities may have a fear of going into the hospital, and it could be potentially a traumatic event for them. So just in terms of a review, as most of you know, there are different types of sleep apnea testing. I've been talking about in-lab polysomnography, and so that's the gold standard and the test that's available for most children. And then most adults will use the type 3 portable monitoring. But what I'll be talking about today is our experience with doing portable home polysomnography, that full polysomnography, that's similar to the type 1 test. And so we know from decades of experience that home sleep testing using the level 2 full polysomnography is pretty feasible in kids. The TUCASA study, which was done in the 1990s, and then the CAP study, which was done in the early 2000s, were similar in that they both enrolled about 200 school-aged children and did unattended ambulatory full polysomnography. And the percentage of those tests which were set up by a technologist or a nurse in the home were pretty good, like about 90% of them were technically adequate. They didn't, however, look at reproducibility in a very large sample, but those that were done had pretty good reproducibility. And you can see that the main signals that they had trouble with were airflow, where kids were taking out the cannula in the middle of the night, or the pulse oximeter, where they were sort of wiggling their fingers out. There were a lot of limitations to these studies. They didn't compare with in-lab polysomnography or really look at any parent-reported measures from those older studies. And there's lots of different studies that have done type 3 testing in children. This is one that was published a couple years ago that was pretty well done comparing type 3 home testing to children with in-lab polysomnography. And you can see, like in most of these studies, the correlation is actually pretty good between the obstructive apnea hypopnea index. In this figure, the lab test is on the y-axis and the home test is on the x-axis. But there's often a significant difference in the values from those two tests. In this case, it was about a mean OAHI difference of 15, which in children is really the difference between not having sleep apnea at all and like more severe obstructive sleep apnea. So that makes it a real challenge, both in terms of diagnosis and to know the severity of OSA. So as a consequence of reviewing this data back in 2017, the American Academy of Sleep Medicine really just felt that there was not enough data at that time to endorse home polysomnography in children. Very few studies had compared in-lab PSG with home polysomnography. Most really didn't use any kind of measure of sleep. They're just doing the level 3 tests, and most excluded more medically complex kids that we see a lot of in clinic. And they really didn't look at parent and child factors. So some of the advantages of doing the level 2 home polysomnography is you can identify sleep. This was from one of the early studies we did looking at children with Down syndrome. And you can see in that red box, this child was awake for like the first 4 hours of the study. And we were able to easily determine that because we had an EEG the whole time. So we were able to do the staging, and then we scored the respiratory events only in the time that the child was asleep. And you can clearly see from this epoch that this child's in N3 sleep. The other advantage is that you can identify microarousals. And in children, many of the events are hypopneas, and many times they're scored due to microarousals. So by doing full polysomnography, where we have the ability to detect those arousals, we can detect a lot of these hypopneas that make up a big chunk of the OAHI in kids. And there have been some studies that have removed the EEG leads from in-lab polysomnography, and you often will underestimate the severity. So we set up a series of studies that I'll go through some of the the data from the published studies, and I'll just briefly mention some of our ongoing trials, looking at the type 2 home polysomnography with in-lab tests. And the basic aims of these all are going to be looking at feasibility, looking at tolerability and family-reported perceptions, and then the diagnosis for sleep apnea, not always in moderate to severe. And so we would have the kids come in, we would do a medical record review, have them do consent, do a history and physical exam. They would fill out some questionnaires. We would do home polysomnography, and then we would do the in-lab test with all of them, and then have them do some questionnaires about how they felt about the two and comparing the two. The first test I'll go through, this hasn't been published yet, but this was sort of our pilot trial, where we enrolled just 15 kids, and we were using the A1 device for these tests. And again, every child in the test completed both in-lab polysomnography and the home sleep testing. And you can see here, we had a nice representation in terms of males and females, race and ethnicity, and we were really aiming for a broad age range just in this initial pilot study. So we had kids as young as 2, and then we had some adolescents as well. And we asked them these results, whether they felt the home polysomnography was easy to use, appealing, or met approval, and the vast majority found that it was. Interestingly, the preference between the two tests was somewhat variable. So some families preferred home polysomnography, and some families did actually prefer the in-lab test. Those who liked the home test felt that it was accessible, it was easy, it was convenient. They felt comforted by the fact that they were in their home. But those who really didn't like it felt that it was stressful to have to manage the equipment themselves, and it was a long, long night. When we compared the accuracy of the two tests, we used an obstructive apnea-hypopnea index cutoff of 2, which is very low, but we use that intentionally because in children, the cutoff is typically between 1 and 2 events per hour. And out of the 15 kids, there was agreement between 14 of the 15 between the home polysomnography and the in-lab test. And you can see here that the OAHI values are fairly representative, actually, what you see in pediatrics. So about 50% of kids we know from the childhood adenotonsillectomy trial that are referred for polysomnography actually will have a diagnosis of OSA using this threshold of 2 events per hour. So we felt like we had a really good normal representation of children, and that this test performed really, really well. It had a very, very strong correlation between the two tests. So the next study that we did, which was published last year in Journal of Clinical Sleep Medicine, was looking at home sleep testing in children with Down syndrome. We looked at this population because we know obstructive sleep apnea is very prevalent. Up to 90% of children with Down syndrome have sleep apnea. They have a lot of comorbidities, and all of them should have a sleep study by the time they're 4 years old, but we know from lots of data that they don't. And we feel like one of the reasons is probably access to the test. So we know from some preliminary work that's been done by Pablo Brockman and others that it's been shown to be feasible, but we really didn't know about diagnostic accuracy. So we spent a lot of time setting this study up to try to get success. This was funded through an R21. My colleagues Andy Kelly and Ignacio Tapia were the co-PIs of that study, and we aimed to recruit 40 children between ages of 5 and 25, so we had some young adults too. And again, they did both the tests and then completed some questionnaires. And this is just a picture of one of our techs doing the setup for one of the young people in this study. We spent a lot of time preparing for this, so we created these storyboards to try to explain to families what they were in for with these tests, and then we worked with our media team to have videos available so that families, before they came in for the test, could watch the videos and be sort of prepared for both the in-lab test as well as home polysomnography, and those are available on YouTube that people can still view. And so this started right at the beginning of COVID, so we were very worried we were going to have trouble with recruitment, but families in this community were overwhelmingly really interested in the study. We approached 63 people. Actually, some of these people were coming from hundreds and hundreds of miles away that wanted to come to participate. We ended up recruiting 43. And what was really nice was that out of those 43, and many of these kids had autism, anxiety, and a lot of other comorbidities, 41 were able to complete the in-lab polysomnography and have an acceptable test. And the same number were able to complete the in-lab test. There really wasn't any difference in terms of feasibility. And the kids slept significantly more, about an average of about an hour more on the home test than in-lab. And so when we looked at the acceptability data and asked them to compare, this was strikingly different than in that pilot study. Overwhelmingly, these families agreed that the test was possible and doable and met their approval, and they also preferred the home test compared with in-lab, which we were a little bit surprised at. We felt like with this medically complex patient population, some were going to really struggle at home. but it was kind of the opposite. And then when we compared the OAHI parameters, we used a cutoff here of 5 events per hour because we're dealing with a population where the pretest probability of obstructive sleep apnea was much higher. We found that the accuracy was about 80%. And interestingly, we identified 2 kids who did have obstructive sleep apnea based on the home sleep test, but not in the in-lab test. So we felt that there could be some night-to-night variability at play, or sometimes there may be environmental factors, in which case the home test may actually more accurately represent sleep apnea than in the lab. And I'll just briefly mention the couple studies that are going on now. One is this NIH-funded trial that's expanding some of the work that I have just kind of gone through. We're in year 2 of this study and working on it with my colleague at University of Miami, Ignacio Tapia, and then we have 3 clinical expert sleep physicians who are working with us, Sally Ward at Children's LA, Lourdes Del Rosso, and Angelique Gallion, all in California. And so the design here is similar, but we're randomizing participants in this study to either have the in-lab polysomnography or the home polysomnography in the order, and then they get crossover to the other study, having them complete some of the same questionnaires. And this is children that are age 5 to 12. So we're not looking at the adolescents, but we're also not looking at infants here. We're aiming to have 100 of those 317 participants with Down syndrome. And these other colleagues that I mentioned, their role is actually to look at therapeutic decision making. So it's one thing to look at AHI and what is the similarity or difference in AHI, but the other thing is, okay, as the physician, how are you going to actually treat this patient? So we sort of give them all the demographic factors and then the results of either the home sleep test or the in-lab sleep study, and ask them, okay, would you send this patient to adenotonsillectomy or not? Because what we're interested in is, even if the OAHI is not perfectly aligned, if these patients are going to end up getting the same treatment anyway, that's a really important sort of separate metric to look at. And so we've recruited about 120 participants into this study so far. So it's going really well, and families, again, are overwhelmingly really excited to participate in this opportunity. And then the last one I'll mention that was just presented at this morning's poster session by our fabulous coordinator, Yalis Roman, who's here in the audience, is similar in design, but we're really here looking at the ability for home sleep testing to assess for residual obstructive sleep apnea after adenotonsillectomy. So most of these kids who have a TNA never get reevaluated for sleep apnea, so we don't really know how effective the treatment is. So potentially home polysomnography could be a way to assess that too. And so here we presented the first 30 participants in this trial, and we're going to have 60 total. And I'm working on this with my colleague, Nancy Lynn. And again, we found that the children at home sleep significantly more because they have more control over when they're going to sleep. They actually wake up significantly less than they do in the sleep lab. And the parameters in terms of AHI and the sub-indices are all very similar between the two. If you look at the means, I mean, they're almost identical in terms of the indices. And again, we've had some participants who have met that threshold of 2 vents per hour in the lab, but not in the home environment, and some the other way around. So there could be some night-to-night variability or other environmental factors at play there too. So just in conclusion, I'll just say that level 2 testing is feasible across a wide spectrum of children. It could be in some families preferable to in-lab polysomnography. There's some emerging data that suggests that level 2 home sleep testing has good accuracy compared with the in-lab test, but we do need more data to assess the impact on actual clinical care. And part of this task force now that's reviewing this literature to try to see if these guidelines can be updated. There's been a lot of additional research, which I didn't have time to go through in the last few years in this area. And that's it.
Thank you so much, Dr. Cielo. Such an exciting innovation. The necessity is the mother of innovation, and that's certainly an example of it. And we really appreciate that insight. Next, we have Dr. Yaggi. Dr. Klar Yaggi is professor of medicine at the Yale University of Medicine and director of the Yale program in sleep medicine. He is board certified in internal medicine, pulmonary medicine, critical care, and sleep medicine. He is a principal investigator at the National VA Clinical Epidemiology Research Center. His research interest is the clinical epidemiology of sleep-disordered breathing, focusing on the diverse health implications of sleep apnea and emphasizing informing clinical care. Within this larger domain, his work is focused on three specific topics: sleep apnea as a risk factor for advanced cardiovascular and metabolic health outcomes, prognostic factors for adverse cardiovascular and metabolic health outcomes in patients with sleep-disordered breathing, and the impact of diagnosing and treating sleep apnea using home-based strategies on cardiovascular risk. Please welcome Dr. Klar Yaggi.
Thank you very much, Emerson. It occurred to me that we're really missing an important scientific opportunity right now. I think everybody in the room should be wearing a Nox A1 device so that we can actually study the impact of a presentation on ambulatory polysomnographic methodology on postprandial napping this afternoon. I think we would need to stratify, though, between those who got the turkey sandwiches and those who didn't get the turkey sandwiches. We use this type 2 device in a number of different domains. I was asked to share a little bit about our experience in using this in a really challenging population of patients, those with opioid use disorder. But we have a number of different studies going on at Yale right now in a number of very distinct samples. And so in addition to patients with opioid use disorder, we're using this in the acute stroke setting in the hospital to diagnose and treat sleep disorder breathing. We're using this in the intensive care unit as part of an intervention, a chronobundle intervention to improve circadian rhythmicity in the intensive care unit. We're using this among older patients and a geriatric population to study sleep among older adults and the feasibility of using this technology in a less mobile and slightly more impaired population. We really got interested in this methodology in particular because of its ability to generate some of the endotypes and phenotypes of sleep apnea. And we have a study going on looking at arousal threshold and how that might predict those people who are able to adhere or not adhere to CPAP therapy. And because of its ability to endotype, now we can do mechanistic clinical trials looking at how new pharmacologic medications can also impact some of the mechanisms for developing sleep apnea. So I'm just going to talk a few minutes about the project that we're doing in this population among patients with opioid use disorder. I also do not have any disclosures, I think, besides the box of lunks that I got that was not turkey. But based on how many studies we're doing this, Emerson should have some more conflicts for this talk. All right. What we're briefly going to do is talk about sleep deficiency across the trajectory of opioid use disorder. We're going to talk about some of the neurocognitive, neuropsychiatric, and socioecologic mechanisms of impaired sleep among these patients. I'm going to share the study design of the CLOUD study, which we've just completed recruitment and follow-up for, and share with you just a couple of examples of the data quality that we can get from this device. So the clinical problem that we have been focused on in this particular study is that we know that effective evidence-based frontline treatments exist for patients with opioid use disorder. There are FDA-approved medications, what we term medication for opioid use disorder, methadone, buprenorphine, but there's really significant variability in treatment responses. We know that relapse or recurrence of non-prescribed use is very high in this population. That leads to lack of retention and a continued cycle of recurrent use. And so there's been a critical need to identify novel strategies and new approaches to complement and enhance treatment for opioid use disorder to improve retention, reduce recurrent illicit opioid use that leads to a huge number of overdoses and deaths in this country. And one promising strategy is targeting the neurobiologic system that might be linked to relapse with this addiction, and namely sleep deficiency and circadian biology. Sleep disturbance, as we'll talk about, is common and often severe in patients with opioid use disorder. And several years ago, the FDA had a public meeting that largely included patients with opioid use disorder who really stated that one of the key reasons for going back to recurrent use was impaired sleep. We know that sleep deficiency accompanies the trajectory of this deficiency of sleep. Sleep deficiency accompanies opioid use disorder really across the trajectory of this addiction. We know that certain circadian rhythm disorders, such as social jet lag and delayed sleep phase, increase and predispose to addiction vulnerability. We know that patients who are undergoing withdrawal or supervised withdrawal from opioids have increases in sleep latency, decreases in total sleep time, and a number of symptoms predisposing to insomnia. We know even patients in recovery who are getting treatment for their addiction have 90% of them report poor sleep quality. And importantly, many opioid-related deaths occur during sleep. When the respiratory drive suppression that occurs with sleep, compounded with the use of opioids, be it MOUD or non-prescribed opioids, come together to impair control of breathing and lead to respiratory failure and death. And what really got us interested in this space in particular is in using this construct of sleep deficiency, which involves both inadequate sleep duration, so sleep deprivation, non-circadian sleep, so measuring when people are sleeping out of sync with their underlying circadian rhythm, or poor sleep quality, so not getting all the different types of sleep, impaired sleep architecture, often due to underlying sleep disorders like sleep apnea or insomnia. Is that there are a number of plausible mechanisms by which this may actually impair and contribute to worsening addiction. Some of the same domains that are impaired among patients with opioid use disorder, executive function, incentive salience, depression, and so forth, also occur in patients with sleep deficiency. And there are also a number of neuropsychiatric mechanisms that are linked to sleep that may mediate some of the adverse outcomes in these patients. Stress, pain in particular, mood, etc. And so this really fascinated us, that the same neurocognitive domains that are impaired in addiction are also impaired in sleep. Executive function, reward processing, incentive salience. And this connection between impaired sleep, pain, and opioid use. We know that impaired sleep lowers pain threshold, leads to heightened pain, which may contribute to increasing or dose escalation of opioids. And this hyperalgesia, particularly related to N3 deficiency, leads to this sort of vicious cycle of impaired sleep, lowered pain threshold, and greater opioid use. We also know that there are probably a number of social ecologic factors that impact sleep at the individual level, societal level, and social level, factors that accompany this addiction that probably impair sleep as well. And this just to sort of demonstrate the magnitude of this problem in this population of patients. This is a study recently published by Caitlin Martin. About 80 to 90% of patients who are on MOUD are using benzodiazepine, Z drugs, or other drugs to help improve their sleep at nighttime, or self-medicate with cannabis or alcohol, etc. And so our study was trying to get at some of these pathways, and what we did is enrolled about 220 patients from an opioid treatment program, a large open opioid treatment program in New Haven, Connecticut. And we did some very detailed phenotyping on these patients. So we did Nox A1 SAS device, which is a self-applied montage on these patients. They underwent fMRI testing, so we can actually examine how sleep deficiency impacts some of these neurocognitive domains. They got a very detailed neuropsychiatric assessment, and we also monitored their home environment with respect to sound and light exposure. And we followed these patients over a 6-month period of time, and our primary outcome was how much opioids were they continuing to use over that period of follow-up. follow-up in recovery. And so we're interested in sort of looking at neural fingerprints that might predict recurrent opioid use and distinct patterns between those with and without sleep deficiency, look at some of the mechanisms, the biologic, psychiatric, and other mechanisms, and really focus on some of the social ecologic factors that may be at play. This is a population of patients who are using opioids who are also very high risk for sleep disordered breathing, both obstructive sleep apnea from the opioids affecting muscle tone on the upper airway, and of course central sleep apnea. And I think one of the other advantages of this type of type 2 device is that in addition to understanding, as we know, some of the anatomical predisposition to sleep apnea, what we can do with this device is actually look now at some of the non-anatomic physiologic traits that I'm sure people have been hearing a lot about in this meeting and other meetings. And it turns out that about over 50% of patients with sleep apnea may have some of these non-anatomic endotypes and phenotypes that predispose to their sleep disordered breathing. So not all patients get sleep apnea for the same reason. And it used to be that in order to derive some of these endotypes and phenotypes, we would have to do very detailed measurements in a physiology lab with esophageal pressure monitoring and changes in manipulating changes in CPAP flow. But we now know that we can actually derive some of these endotypes from standard polysomnography. And in fact, one of the appeals of this type 2 testing is that together with the Harvard group, they've developed a pretty scalable approach to be able to derive some of these endotypes because this is a full type of type 2 testing. And that is really, I think, what got us interested in this. And I'm just going to share with you some sample of data from patients with opioid use disorder, that many of whom have housing instability, living in halfway houses, and we're able to do this technology and get to these patients by using this technology. And so this is a snippet, a 30-second snippet of N1 sleep, a pretty clear sleep spindles, and N2 showing evidence of hypopnea and oxygen desaturations, post-arousal central apnea, and a longer duration of time. REM sleep, which is very clear in this image. We use, as opposed to 1020 montage, we use a self-applied FAAST montage in our work because we're going to where the patients are in our studies as opposed to having them come into a sleep laboratory. And so REM sleep can be a little bit tricky, but our data suggests that it's been very easy to distinguish because the frontal montage goes over the forehead and you can sometimes capture eye blinks, but we've not had really any issues. And it didn't take our scores very long to sort of acclimate to that. Just some other examples of obstructive events occurring in REM sleep, more obstructive events, and we saw a ton of central apneas in this population related to their use of MOUD. So I'll just stop there. These are some of the co-investigators that contributed to the work in this population. We're very interested in getting this work now published and analyzed, but this technology was extremely helpful in our being able to reach these patients. So thank you for your attention. Okay.
So first, I want to thank Dr. Cielo and Dr. Yaggi for coming up and sharing your work with us. It's a really important topic, and we really, really appreciate it. I'm Heidi Riney, if I don't know everyone here. I'm Chief Medical Officer here at Nox Health. So I want to open up for questions for everyone, but I want to ask a question first. Before I go there, I told Dr. Yaggi this, but I don't get a lot of street credit at home with my kids for doing sleep. Actually, it's often the opposite. They're teenagers, and so I will say I'm a little bit of a buzzkill when I talk to them about when to not drink caffeine, when to not watch TV, how much sleep to get. So I will say every morning we watch SportsCenter as part of our routine. It's just kind of our thing to do. And I don't know if anyone saw SportsCenter recently during the playoffs, But Dr. Yaggi was on there doing a segment with a lot of big NBA superstars. So we had, Anthony Edwards, or the Ant-Man. We had Steph Curry. We'd had LeBron, all talking about the importance of sleep for performance. So I think we know that, that it matters, but it was really wonderful to hear this and to have these NBA players say how important it is. And when they don't sleep well, they don't perform well, and that there's the importance of napping beforehand. And so for once, they actually thought that, yes, sleep is very cool. And when we said I was going to be on the stage with you, they were like, oh, now we perked up, and there's a legitimate person here who knows. So had to throw that out there.
I think that's the only time in my life I'm going to be on ESPN. Anyway.
You never know.
So it was all these gorgeous athletes in this sort of chubby academic taking a nap in his office, the open. But the line at the end of the clip was, we should stop saying to athletes, if you snooze, you lose. If you snooze, you win.
Totally. It works. That was great. So I do have a question for both of you. One about, I know we're doing this in clinical research, and that's great, and we definitely have a need to get this out, I would say, in clinical practice. There are a lot of patients who don't have access to care and access to studies. So one, definitely want to hear more about the experience of using the SAS versus the full A1. And then, are there certain populations that you would want to have, the full-scale A1? I know, Dr. Kelly, you work with Pediatrics. And so just to get your take a little bit about both and maybe why you chose that.
Yeah, I think as a researcher, it's helpful to have as much data as you possibly can, because it's a situation where we could subtract, for example, the EEG data and see how that affects the outcomes. But if you don't have that in the first place, it makes it really difficult to know how it would impact the scoring. So our hypotheses have always been that having EEG data, again, to be able to determine whether the patient's awake or asleep, and with arousals really is going to affect the outcomes in terms of the OAHI. And there really have been, there's really a paucity of research in pediatrics, comparing in-lab polysomnography, which is the gold standard, with these other tests. So that was kind of our rationale to do the type 2 testing that we're doing now. And I think that, it remains to be seen just which signals we actually need in order to make the diagnosis. And I think some of the endotyping that you were talking about, that may be there as well in children. It just hasn't been as well studied. But I think having the data that you're able to capture with this system, in particular, and also just the way you can extract the data and do more analysis with that, has made it a great solution from a research standpoint. So.
Yeah, I actually think it was really interesting to hear about some of the barriers to doing ambulatory testing in a pediatric population, and contrast that a little bit with what we're doing in adult sleep medicine. We all know that sleep apnea, there's 1 billion people on the planet who have this disorder, and we can't bring them all into sleep laboratories. And ambulatory testing was initially approved in adults really as a screening test solely for sleep apnea, and it was based on randomized controlled trials that compared sort of more inpatient pathways, a full diagnostic study followed by titration study, to more of an outpatient pathway of ambulatory testing and auto-titrating CPAP. And these devices correlate very well with in-lab testing, but what the decision was based on the fact that there weren't significant differences in outcomes of patients with respect to adherence and how they're functioning and so forth. And so I think clinically in the adult side, it was out of necessity in order to try to get patients into therapy and adequately treated. And this is still an underdiagnosed problem. I think the value of the Nox A1 compared to the T3 is that we get EEG data with this device that most of the ambulatory testing do not provide. And so that allows us to get at arousals, at these endotypes and phenotypes, get EEG data, sleep architecture data, and we've been mainly using that in research studies, and it has been an invaluable tool in research studies. But you can imagine using this therapy in a clinical setting. I think our experience with the FAAST montage is that it is incredibly easy for patients to apply. We give them basically a cartoon step. It's a frontal montage, and the data has been very good with respect to EEG, and it's allowed us to get this extra level of data.
That's great. Thank you both. Now, anyone have any questions? Oh, perfect. We can hand microphones out here. Oh, thank you. Sure. Here, I can hand this over. Perfect. Yeah, absolutely.
Peter, thank you for sharing that. That's very exciting. And I think what you just said is incredibly important, and us thinking very carefully about, I think one of the, in my mind, one of the limitations of home sleep testing as it stands right now is particularly among women with sleep apnea, where we tend to, because we're not measuring arousal and not measuring EEG, and they tend to have, at least premenopausally, more REM-related sleep disorder breathing. We are really underdiagnosing sleep apnea among women, and so this could be a really helpful tool in that context. Are there going to be, I assume there are going to be different reimbursements for in-lab study versus type 2 study? That's very interesting. Yeah. I mean, it also speaks to certainly the endotyping is not ready for a clinical prime time, but the promise of of that therapy is to allow us to practice more precision-based sleep medicine, where you have a certain endotype of sleep apnea might point you instead of a CPAP for all approach to potentially alternative therapies, medications, et cetera. And so bringing type 2 devices in that allow us to get that EEG data, that allow us to do these endotyping could be very valuable in that context.
Absolutely.
If I just want to make sure I heard, why do I think it's not yet ready for prime time? I think it is really changing our field right now, but I think we are still looking at the validity and the reproducibility of measuring these endotypes over time in patients. I think the Harvard group has led the way. They developed this. And I know with Susan Redline, I think they've endotyped over 8,000 patients. And we're starting to see differences in different epidemiologic populations. But I still think there are real concerns about the reproducibility of these endotypes over time. And I think we just need more clinical, patient-oriented research looking at these endotypes before ready for prime time.
Any other questions? All right, I'll think of some more. So I thank you for that point about, you're right about the importance of type 2 and making sure that we do it right. You know, I do think of all the populations of people. I agree with women being one where we know they have more arousals. They tend to be underdiagnosed. Type 3 testing is not often ideal, but also people who can't get to a lab. You're right, time is one component, and you're right, that can't be the only answer, but there are so many people who don't have access to labs, and we want to make sure we do it right by them so that we don't lose that option, because I think there are many that we have to serve, and many who actually have, you know, we always think about, you know, sleep, you know, affecting cardiovascular outcomes and chronic conditions, and these are the people who often don't have access to care, and if we can't provide that access, you're right. I mean, I think that's what we want to do as a field, is find ways that we can increase access as much as we can.
I'll make one other comment. I don't know how many in the room here have that difficulty, but it's still in many areas of the country, Medicaid patients can't get to PAP unless they have an in-lab record.
Exactly.
The implication is a type 1. Now, maybe we should think about going regionally and saying, look, we can do this cheaper. How about let us do an unattended type 1, meet your ridiculous criteria to spend more money to get to PAP therapy, and now we have better access
Right.
for these patients. It's terrible that Medicaid patients can't get this. This is a thought that I have, but I don't know where to go with it.
No, you're right. And with Medicare, too, if they don't meet the criteria, they have to start the process all over again, even though we have a diagnosis and nothing's changed in 6 months. But we're spending all this money to have them restart it. So you're absolutely correct. All right. Well, thank you all so much. Thank you, Dr. Yaggi. Thank you, Dr. Cielo. We really appreciate you coming. And thank you all.
Change a little bit. Yeah, exactly.
Carol?